Hello, everyone, and welcome to another episode of Heart Success Podcast. Today, we will be talking about the trials that were presented at ACC 2020. As you know, because of the coronavirus pandemic, the meeting in Chicago was canceled and turned into an online-only meeting. Unfortunately, with everything going on, I think the meeting fell under the radar, but there was a lot of high-quality research presented at this meeting. And we thought this would be a great opportunity for us to bring forth all the good data that was presented at this meeting, because there were several large studies, some of them potentially practice-changing, that were presented at this study. So to start us off today, we have Garima Dahiya with us. Garima, as you know, is a medical resident at the University of Allegheny in Pittsburgh, Pennsylvania, soon to become a cardiology fellow at the University of Minnesota in Minneapolis. Welcome to the show, Garima.
Thanks so much, Mehak. It's an honor to be back on the show. How are you doing?
I'm good, Garima. I'm good. Just getting off a 1.5-week service on the heart failure team. How are you doing?
I've been doing well. You must have heard I'm currently in Allegheny County, and fortunately for us, the cases have started to plateau for the past few days. So things are not as dire as we initially expected.
That's always good to hear. And looking forward to starting your fellowship in just a little over a month, I'm sure.
Yes, I'm actually very excited about getting started. It's been a little harder than it originally would have been, just because going back and forth, I haven't been able to travel to Minneapolis to, connect with my co-fellows or look up apartments and so on. So it's been a little challenging. I'm also very nostalgic about leaving Pittsburgh. And like I said, because of the social isolation measures, it's been very hard to see my colleagues here or visit some of my favorite restaurants around town. But, nonetheless, I'm still very excited to get started with the fellowship in a month's time.
What about graduation? How are you guys going to do your graduation celebrations?
That is a very good question, Mehak, and we've all been badgering our program director, asking him this question back and forth over and over again. A couple of weeks ago, the answer would have been a virtual graduation, just because our cases were still on an upturn. But seeing how things are progressing for the past few days, I'm not really sure what the answer to that question is, but I'm kind of hopeful we may in fact be able to have an in-person graduation.
That's nice. I remember my residency graduation is always great, and so many great memories.
Right, yeah.
So, Garima, I think we were going to talk about 3 specific trials today. We were going to talk about Partner 3, popular Tabby, and the Spiral Hypertension trial. And, all 3 randomized control trials, all 3 very interesting results. So why don't we start our discussion with the Partner 3 trial? And this was a trial that evaluated transcatheter aortic valve replacement, as everybody knows well, TAVR, compared with surgical aortic valve replacement, or SAVR, among low-risk patients with symptomatic severe aortic stenosis. As you know, Partner 1 and 2 being previously published, and the Evolute trials have been published in the intermediate, high, and prohibitive risk patients with aortic stenosis. So this really brought forth the lowest risk population to date. Garima, why don't you walk us through the study design and method?
So like you said, this was one of the more awaited trials that the ACC presented in March. The Partner 3 was an open-label, parallel group randomized control trial that looked at patients at low surgical risk that were randomized to either the TAVR or TAVR using the SAPIEN 3 valve or the SAVR group. The mean patient age in this trial was about 73 years. About 70% of the patients included were male, as opposed to 30% females. The inclusion criteria of the trial was basically all symptomatic patients with high gradient aortic stenosis, patients who were suitable for a transfemoral access, or patients whose STS risk of 30-day mortality was less than 4%. So this was the inclusion criteria for the trial. With regard to the exclusion trial, and this is important to note, that patients who had an ejection fraction of less than 30% were excluded from the study. Patients with bicuspid aortic valves were excluded, and those with high clinical frailty, as was assessed by the VARC2 criteria, were excluded from the trial. There were some other exclusion criteria, such as a recent MI within the past month, any stroke or TIA within the past 3 months, or patients with severe valvular issues. So those with severe AR or MR, or those with moderate MS, or any pre-existing mechanical or bioprosthetic valves were excluded from the trial. About 503 patients ended up being randomized to the TAVR group, as opposed to about 497 patients in the SAVR group. So it was almost an equal number of patients in both arms. Like I said, the male to female ratio was 70 to 30%, and the mean patient age was about 73 years. In terms of the other important comorbidities, for instance, those with diabetes were about 30 to 31%. And patients were followed up for about 2 years post-procedure. Those in the TAVR group received aspirin and Plavix, about 300 milligrams before the procedure, and dual antiplatelet therapy for 1 month after the procedure. So this is kind of where we stand about the study, the study methods. Would you want me to go ahead with the outcomes and results as well?
Yeah, absolutely. And, I think it's important for our listeners to realize that bicuspid aortic valve patients have never been included in any of the partner trials. So it's important to know that this group of population has not really been studied in a randomized control fashion. So yes, Garima, please walk us through the results of this trial.
Right. And just to add on to what you were saying, Mehak, in terms of the exclusion, you talked about the bicuspid aortic valve. Another point to note is the clinical frailty that we mentioned. So they followed the VARC2 recommendations, but patients basically were excluded based on their 5-meter walking time, their grip strength, a BMI of less than 20, those with serum albumin less than 3.5, or cognitive impairment or dementia pre-existing before the trial. So it was, in a way, a very strict exclusion criteria from the aspect of frailty. Moving on to the study, the primary and the secondary study outcomes. So the primary outcome of the study was all-cause mortality, stroke, or rehospitalizations related to either the procedure, valve, or heart failure. At 1 year, it occurred in 8.5% patients in the TAVR group, as opposed to 15% patients in the SAVR group. And the P was significant. It was less than 0.001 for non-inferiority, as well as for superiority. This is with regard to the primary outcome. From the aspect of the secondary outcomes, stroke at 30 days was significantly different between the two groups. That is 0.6% for the TAVR as opposed to 2.4% for the SAVR group. New onset AFib was significantly different. Only 5% patients in the TAVR group as opposed to nearly 40% patients in the SAVR group had new onset AFib. Death or disabling stroke was about 1% for the TAVR group. This is at 1 year intervals as opposed to 2.9% for the SAVR group, also significant. The length of stay was another significant difference between the two groups, which is 3 days for the TAVR group as opposed to 7 days for the SAVR group, which I suppose is to be expected for an interventional versus an open heart surgery approach. With regard to the permanent pacemaker requirement secondary to conduction abnormalities at 30 days, it was 6.5% for the TAVR group or 4% in the SAVR group, which was a non-significant difference between the two. Another thing to note is the Kansas City Cardiomyopathy Questionnaire, which was the way of assessing functional status differences between the two. And this was fairly remarkable at 30 days. It was 3.9% for the TAVR group as opposed to 30.6% for the SAVR group. So this is kind of where we stand with the primary and secondary outcomes of the study.
And do we have any long-term outcomes among these low-risk patients?
Yes. So the mean age of time of follow-up is 1 year, but we also have longer-term outcome follow-ups for these patients, which was at 2-year intervals. And the primary outcome, which was death, all-cause mortality, stroke, or hospitalization related to procedure, valve, or heart failure, this was 11.5% for the TAVR group and 17.4% for the SAVR group. So the primary outcome is significantly different between the two groups, even at 2-year follow-up intervals. And the same thing holds true when you stratify them a little bit further. So when you look at rehospitalization rates between the two, it was 8.5% for the TAVR group and 12.5% for the SAVR group. It was just at the cusp of significance. When you look at specifically at death or disabling stroke, it was similar between the two groups. So in the TAVR group, it was 3% and it was 3.8% between the SAVR group. So again, a non-significant difference between the two. When you look at valve thrombosis, this was a significant difference between the two. And when you looked at the mean transvalvular gradient 2 years after the procedure, it was 13.6 millimeters of mercury mean gradient with the TAVR group and 11.8 millimeters with the SAVR group. What's interesting to note here is that when you look at the death rate at 2-year intervals, P-value is actually non-significant. Death or disabling stroke between the TAVR and the SAVR groups. It kind of equalized between both the arms at 2-year intervals, which really begs the question, are these significant values that we noted at the 1-year follow-up, are these really going to hold true on longer-term follow-up at 5-year or 10-year intervals?
Yeah, that's a very interesting point you bring up. And, I'm sure over time, as we get more long-term data on these low-risk group patients, we will definitely be able to tease these out better. The other thing I think that is very interesting was the hemodynamics across these valves. Historically, if you look back at the previous partner trials, TAVR was usually superior when it came to the mean transvalvular gradients because hemodynamically, the TAVR valves, because they don't have the sewing ring, have been overall better. But I think in this specific study, because 70% of the patients were male, and surgically, most of these people were able to get larger valves. Surgery ended up actually having a much better mean transvalvular gradient. Very interesting that with larger surgical valves, you can achieve the same degree of hemodynamic optimization to a degree. Because as we know, when you have higher gradients and potentially smaller valves, patient prosthesis mismatch, this in itself is independently predictive of worse outcomes down the line. So far looking pretty good for surgery on that aspect compared to previous trials.
Right. Yeah.
Can we discuss the health status after TAVR in this low-risk patients with aortic stenosis?
Right. So the way they assessed health status in this trial was by the Kansas City Cardiomyopathy Questionnaire, which we all know is a questionnaire that was developed with 5 domains of health status, essentially, which is physical function, social function, symptoms, quality of life, and self-efficacy or knowledge in patients with heart failure. The score is set up from 0 to 100, and a higher score indicates a better health status. So in this trial, patients were evaluated at baseline 1 month, 6 month, and 12 month intervals post-procedure. So at 1 month, they noticed a large improvement in health status after TAVR as opposed to surgery, which of course is to be expected because, the time to rehabilitation after open heart surgery should be expected to be longer than someone with TAVR. And the mean difference in their KCCQ scores was about 16 points, which was statistically significant. When these patients were followed up to 6-month interval, this difference between the two groups lowered. So at 6-month intervals, there was only a 2.6 point difference favoring TAVR over SAVR with a p-value of 0.04. And at 12-month intervals, this difference dropped a little bit more, and it dropped to about a 1.8 point difference favoring TAVR over SAVR, with the p-value still holding significance. The proportion of patients with a good outcome, that is alive and with a KCCQ score over 75 and no significant decline from baseline, was greater with TAVR as opposed to surgery at 6-month intervals as well as at 12-month intervals with significant p-values for both. But it's interesting to note that with passage of time, the difference in KCCQ scores about whether they underwent TAVR versus SAVR, there was only a 1.8 point difference between the two groups.
Thanks, Garima. If we are to conclude what are the significant findings of this study, maybe if you could just put them in one line together, because TAVR clearly was superior in this study.
Right. So I guess the one line to take away here, Mehak, would be that among patients with low risk, surgical risk with severe symptomatic aortic stenosis, TAVR is superior to SAVR at preventing death, stroke, or rehospitalization at 1 year, and the benefit is sustained at 2-year intervals. But again, I always kind of relay these findings with a pinch of salt, here being that we're unsure about whether this benefit would be present at 5-year or 10-year intervals as well.
And that's the best part, that they are going to follow these patients for 10 years. So we will get data over the next 8 to 10 years.
Right. Any drawbacks to the study, in your opinion, Meg, that kind of came up while you were going through the trial?
I think, I did see that the outcome adjudication was not blinded. That does potentially induce a degree of bias when it comes to outcomes ascertainment. Also, there were differential dropout rates after randomization, 40 plus in the surgery group, 7 in the TAVR group. However, the authors did a secondary analysis and showed us that when they imputed for the dropout, the results really did not change. So the primary analysis persisted when they did an imputation analysis. So that was relatively reassuring, because all studies at the end of the day will have dropout. Overall, I think when it comes to whether or not this study would change practice, I think TAVR has already changed practice. So I don't think this study would change anything that we do significantly. It does bring into this low risk group of patients. However, I think what I'll leave it at is that this is not your 55-year-old patient who's come in with severe aortic stenosis and you're deciding whether or not you want to do TAVR or SAVR. That person was not in this study. The mean age of the patients was 73. There was a fraction of patients less than 65 years old in this study. So these are really older patients which are low risk because they're probably not frail. They have good ejection fraction. These are healthy but older, mostly males who were included in the study. So I think it's important to know who was studied and how you cannot extrapolate these results to the other populations. I would just leave it there.
Right. And of course, and again, extrapolations to patients who have reduced ejection fraction, so EFs of less than 30% were excluded from the trial. And I kind of had mixed feelings about it too. It's undoubtedly a landmark trial which is going to expand the penetration of TAVR in the treatment of aortic stenosis. But at the same time, I did see some negative articles out there as well that called this trial as disruptive to current practice. But I stand with you. It's definitely, the 10-year clinical echocardiographic follow-up is definitely worth looking out for. And undoubtedly, this trial is going to change, expand the usage of TAVR for treatment of severe symptomatic aortic stenosis.
Agreed, very well. And that brings us to the next TAVR trial we have, which is the popular Tabby Trial, which is the trial that looked at antithrombotic therapy after transcatheter aortic valve replacement in patients with a long-term indication for oral anticoagulation. So I think the study looked at whether oral anticoagulation alone versus oral anticoagulation plus Plavix or clopidogrel among patients who had a TAVR had differences in outcomes. And there was the recent study which we did discuss in a previous episode, was the Galileo Trial, which specifically looked at using DOACs or direct oral anticoagulants, specifically Rivaroxaban. And that study was interesting because it showed that introduction of DOACs within this population was actually involved with a high risk for bleeding and thrombosis. So that study was halted early. So it's interesting because the role of anticoagulation in TAVR is still unclear, and the role of antiplatelets on top really needed to be studied. So this is a great study, and why don't you tell us about this study?
Right, Meg. This was an open-label parallel group randomized controlled trial as well that was performed at 17 European sites, out of which 9 were in the Netherlands, 6 in Belgium, 1 in Czech Republic, and 1 in Luxembourg. And like you said, patients who underwent TAVR and had a long-term indication for oral anticoagulation were either randomized to the oral anticoagulation alone group versus oral anticoagulation plus Plavix for about 3 months. A total of 326 patients were enrolled in the study, of whom they were split nearly equally, 164 in the oral anticoagulation group and 162 in oral anticoagulation plus Plavix. So we nearly have equal patients in both arms. Patients were followed up for about 3 months post-procedure. Their mean age was about 81 years. And in this study, we have a higher number of females, nearly 44% as opposed to 56% males. The inclusion criteria of the study was just patients who need TAVR and have a long-term indication for oral anticoagulation. And the exclusion criteria were patients who received a drug-eluting stent within the past 3 months, or patients who received a bare metal stent within the past month, or those who have an allergy or contraindication to oral anticoagulation. And some other features to note about the patient cohorts in both arms is about 96% of these patients had AFib. The types of anticoagulation used were about 75% patients were on a vitamin K antagonist, and about 24% patients were on a direct oral anticoagulant. With regard to TAVR, about 87% patients had a transfemoral access approach. And with regard to the valves themselves, about 41% patients had the SAPIEN 3 valve and 30% patients had the Evolut R valve. And about 2.5% of the patients in the study already had an embolic protection device. So the patients were already receiving oral anticoagulation before they were randomized. And those patients were simply continued on oral anticoagulation, which was either a vitamin K antagonist or a DOAC, depending on the drug that they were already using before they were randomized. And these patients then went on to be randomized with a 1:1 ratio and received either Plavix or not for 3 months. These patients were assessed during follow-up visits for routine care at 1 month, 6 months, and 12-month intervals, either by the treating hospital or the referring hospital. And transthoracic echocardiography was performed at 6-month intervals as well after the procedure. And these patients were also asked to fill out questionnaires at 3 months, 6 months, and 12-month intervals after procedure to assess them for their primary and secondary outcomes with regard to bleeding and their medications and health status and quality of life.
And what were the results of the study?
So there were 2 primary outcomes that were evaluated, and that was all bleeding as opposed to non-procedure related bleeding. So all bleeding occurred in 21.7% patients of the oral anticoagulant group, as opposed to 34.6% of the patients in oral anticoagulation plus Plavix group, with a significant difference between the two, with a p-value of 0.01. And among the patients who were treated with a vitamin K antagonist, the relative risk of all bleeding for oral anticoagulation versus anticoagulation plus Plavix was 0.75. And among the patients treated with the DOAC, the relative risk was 0.28. Then with regard to the other co-primary outcome, which was non-procedure related bleeding, it occurred in about 21.7% patients of the oral anticoagulation group, as opposed to 34% of the oral anticoagulation plus Plavix group, with a significant p-value of 0.02.
The way they defined bleeding in this trial was a little confusing. They used the Valve Academic Research Consortium 2 definition for bleeding. WARC 2 classification does not differentiate or distinguish between procedure-related and non-procedure-related bleeding. So to specifically look at procedure-related events, they used a second definition called the BARC, Bleeding Academic Research Consortium Type 4 Severe Bleeding. And the non-procedural related bleeds was whatever was left between WARC 2 and BARC. Eventually, what ended up happening as a result of using these definitions is that something like a groin bleed as a result of the TAVR procedure was counted among non-procedure related bleeding. So it comes down to, I think, more technicality that the non-procedure related bleedings is what really matters here. And that was significantly higher among patients who had an antiplatelet on top of the anticoagulant. When you look at the supplementary, which provides alternative definitions for bleeding, including Gusto bleeding score and TIMI non-cabbage related bleeding score, these were all consistently lower among patients in the oral anticoagulation group compared to patients on oral anticoagulation plus clopidogrel. However, a lot of the times, these numbers were not always statistically significant, but numerically consistently lower bleed among patients on oral anticoagulation.
So how would you conclude those trial results?
So, among patients who underwent TAVR and had no indication for long-term anticoagulation, oral anticoagulation alone was associated with a reduction in the bleeding and procedural bleeding compared with oral anticoagulation plus Plavix. And oral anticoagulation alone compared with oral anticoagulation plus Plavix was non-inferior with respect to major adverse ischemic events. A minority of patients, which is about 24%, were treated with DOAC, and there's still debate if this form of anticoagulation is safe compared to vitamin K antagonist.
Sure. Why don't we move on to our next trial, which is the spiral hypertension off-med study, also presented at the ACC 2020 and published simultaneously in The Lancet. This was a trial on renal denervation as a potential option for patients with untreated hypertension. So renal denervation, as we know, was really a hot topic 6-7 years ago until Simplicity 3 really came out and was negative. And for the last few years, we haven't seen any significant phase 3 or large randomized control data on this specific technology or method. So why don't you tell us why we needed this trial and what's different about this trial and the study design compared to what we've seen before?
Right. So, Mehak, like you said, so this trial was published in The Lancet last year. It actually followed a positive pilot trial that was also conducted by these authors. And once they found promising results, they decided to upgrade this into a multi-center international trial conducted in 44 study sites across multiple countries in Europe and Australia and the US. And this study went on to include patients with a blood pressure of systolic blood pressure of 150 to 180 millimeters of mercury. And they were either randomized to a renal denervation or a sham procedure. The study was designed in collaboration with the US FDA to obtain results to see whether renal denervation could reduce blood pressure in patients who are not taking antihypertensive medication. And I suppose the importance of the necessity of this trial lies in the very fact that uncontrolled hypertension is a predictor of cardiovascular disease, neurological complications, end-stage renal disease, and poses a big burden not just at the individual or societal, but even at the international level. So that's where kind of the importance of the study lies, is seeing if we can perform a procedure on patients with uncontrolled hypertension despite taking multiple medications to see if that can reduce their cardiovascular risk down the line. So this procedure was performed in patients who were with uncontrolled hypertension, whose systolic blood pressure, like I said, was between 150 to 180, and diastolic blood pressure was more than 90, or those in whom the ambulatory blood pressure monitoring readings were between 140 to 170 millimeters of mercury. The only patients who were excluded from the study were those with an ineligible renal artery anatomy, those whose GFR was already less than 45, or those with type 1 or type 2 diabetes who had an HbA1c of more than 8%, or those with secondary hypertension. So the other salient features of the study were, the baseline office systolic blood pressure reading was 163, and the office baseline diastolic blood pressure reading was 101 millimeters of mercury. And with regard to the 24-hour readings, the baseline mean systolic blood pressure was 151, and the 24 diastolic blood pressure was 98 millimeters of mercury. So as you can see, the average, the numbers we're seeing with regard to the blood pressure readings is significantly high, despite these patients being on antihypertensives.
And what were the results of the study?
So the co-primary outcome, which looked at the change in the 24-hour systolic blood pressure reading at 3 months, It changed 4.7 millimeters of mercury in the renal denervation group as opposed to 0.6 millimeters of mercury in the sham group. And the other co-primary outcome, which was the change in 24-hour diastolic blood pressure reading at 3 months, it changed 3.7 millimeters of mercury in the renal denervation group as opposed to 0.8 millimeters in the sham group. The change in office systolic blood pressure reading at 3 months changed a whooping 9.2 millimeters of mercury in the renal denervation group as opposed to 2.5 in the sham group. And the change in the office diastolic blood pressure reading at 3 months changed 5.1 millimeters in the renal denervation group as opposed to 1 millimeters in the sham group. And these were all statistically significant. The secondary outcome included the proportion of patients placed on antihypertensive therapy due to systolic blood pressure of more than 180. It was 9.6% in the renal denervation group as opposed to 17% in the sham group, with a borderline p-value of 0.049. And the major adverse events, which was 0.6% in the renal denervation group as opposed to essentially 0% in the sham group. The numbers here reflect a fairly significant difference between two, especially when you look at the systolic blood pressure readings. They're as far as 9.2 millimeters of mercury is the change you're getting with the renal denervation group at the spot office systolic blood pressure readings, as opposed to, just about 2.5 in the sham group. So that's a fairly significant difference we're seeing between the two.
Very interesting results. Absolutely very favorable for the denervation. And it looks like this was a fairly elaborate denervation process because, like you mentioned, almost 50 ablations needed per person for this procedure. So, I think the only thing I'll mention again is that future trials will always have a sham group, because if you look back at Simplicity 3, there was a significant reduction in the blood pressure within the renal denervation arm, but there was also a significant reduction in blood pressure within the sham group in that trial, which made the difference non-significant in the end. These results are different in that respect. So how do you foresee this trial affecting hypertension management?
So, Mehak, not to sound too negative here, but I don't actually foresee this trial by itself changing practice in any form. I think this trial could be a basis to serve as an example for us to conduct further studies to see whether or not we want to look at, explore renal denervation as a as a therapeutic modality for patients with uncontrolled hypertension. I think the sample size of this study was too little, just about 300 patients for us to include, to spread its applicability. There's racial differences here. We don't know what the percentage of African American or patients of African ancestry were in this trial. The mean age of the patients was 52 years. Only 35% were females. Only 3.6% patients in the trial had diabetes, which we know is a very common comorbidity with hypertension. And like you mentioned, nearly 47 ablations were needed per patient for them to actually complete the process of renal denervation. So I'm going to be wary here and say that this trial is a good example for us to explore denervation as a therapeutic modality, but I don't think this trial by itself is going to significantly change practice in any way.
I certainly hope, once this catheter becomes available for commercial use, care providers will use their discretion and be careful in who they perform these procedures on. Thank you so much, Garima. That was a great summary of these 3 important trials that were presented at the ACC.
Sure, it's my pleasure, Mehak.
One of the larger heart failure trials that was presented was Victoria. This is vericiguat in patients with heart failure and reduced ejection fraction. The drug they used is vericiguat, which is a novel oral soluble guanylate cyclase stimulator. They used it in patients with heart failure and reduced ejection fraction who had either been recently hospitalized or had received intravenous diuretic therapy. This is a relatively new class of drug to be used in heart failure and reduced ejection fraction. You may have heard of riociguat or Adempas, which has been studied in patients with pulmonary arterial hypertension. It has a similar mechanism of action. So this class of drugs
has never truly been tested in this format among patients with HFrEF. It was a randomized double-blind placebo-controlled trial in which 5,050 patients with chronic heart failure, New York Heart Association class 2, 3, or 4, and an ejection fraction of less than 45% were randomized to receive either vericiguat, target dose 10 milligrams once daily, or placebo, in addition to guideline-directed medical therapy in HFrEF. The primary outcome was a composite of death from cardiovascular causes or forced hospitalization for heart failure. The median follow-up was close to 11 months, and the primary outcome event occurred in 35.5% of the patients in the vericiguat group compared to 38.5% of the patients in the placebo group. This difference was statistically significant with a hazard ratio of 0.9, p-value of 0.02. So an absolute difference of roughly 3%. And if you look at the subgroup of whether it came from death from cardiovascular cause versus hospitalization for heart failure, almost the entire benefit in using vericiguat comes from reduction in heart failure hospitalization, because the absolute differences there were 27.4% versus 29.6%. Death from cardiovascular causes occurred in 16.4% in the vericiguat group compared to 17.5% in the placebo group, really not statistically significant. Even when they compared the composite death from any cause or hospitalization for heart failure, the differences remain significant, again, almost entirely driven by rehospitalization rate. Even though the differences were not statistically significant when it came to adverse events, the rate of symptomatic hypotension was slightly higher in the vericiguat group at 9.1% compared to 7.9% in the placebo group, p-value of 0.12. The conclusion of the study was among patients with high-risk heart failure, the incidence of death from cardiovascular causes or hospitalization for heart failure was lower among those who received vericiguat than among those who received placebo. This study was funded by Merck, Sharp & Dohme, which is a subsidiary of Merck, and Bayer. It's a very impressive study. We have only 1 year follow-up, but as you can see, the event rates are very high, even with such short follow-up, telling you how this is a very high-risk population. The study investigators randomized 5,050 patients, but 6,857 patients underwent screening and 1,800 were excluded. So fairly aggressive enrolling. If you look at the demographics, people were in their high 60s, mostly male. 3/4 of the patients were male. 2/3 of the patients were Caucasian. And the study was conducted across Eastern, Western Europe, Asia Pacific, Latin America, and North America. So it was across multiple continents. A majority of the patients were NYHA class 2 and 3, with just 1.3% of all patients being class 4. So really 98.5% of the patients were either class 2 or 3. While this trial was positive, I think it is going to be difficult to use this in clinical practice with a very small effect size at 1 year. Really, like I said, an absolute difference of 3%. That means a number needed to treat of 30 patients for close to 1 year to prevent 1 heart failure hospitalization. Really no effect on overall mortality. We have only 1 year follow-up data, so we need longer term follow-up data to see if this effect persists. However, it does introduce a novel mechanism of action, which is modulation of the nitric oxide soluble guanylate cyclase pathway that generates cyclic GMP in patients with heart failure, endothelial dysfunction, and reactive oxygen species, reduce nitric oxide bioavailability, resulting in relative deficiency of soluble guanylate cyclase and reduced cyclic GMP generation. In contrast to the therapeutic approach of antagonizing counter-regulatory neurohormonal pathways that is characteristics of usual therapies, the ACE inhibitors, RNAs, beta blockers, the MRAs, this is a new drug that enhances the cyclic GMP pathway by directly stimulating soluble guanylate cyclase through a binding site independent of nitric oxide, and by sensitizing this soluble guanylate cyclase to endogenous nitric oxide. So not only does it stimulate this SGC or soluble guanylate cyclase, but it also makes it more sensitive to nitric oxide. That's also how it works in pulmonary hypertension. It works downstream and actually makes it more potent than some of the PDE5 inhibitors. That brings us to the point of safety using with some of these other nitrates. So you can't use these drugs among patients who are already on nitrates. You can't use these drugs among patients that are on sildenafil or any other PDE5 inhibitor for whatever reason it is, because of the risk for severe hypotension. I don't know there's other trials being conducted in this specific pathway for HFrEF, but we do know that this pathway is also being actively studied in patients with HFpEF, where we may expect some benefit because it does work on peripheral vasculature and the nitric oxide pathways, which we know are fairly critical in patients with HFpEF. The other worry I have is among patients with heart failure and reduced ejection fraction, a lot of the times using pulmonary vasodilators, because these are pulmonary vasodilators, can worsen shortness of breath, can worsen their pulmonary edema, but there seemed to be no signal of that in this study. That is one of the reasons why we don't use sildenafil very commonly in patients with HFrEF, especially among patients with high veg pressures. Sildenafil itself has truly never been studied very well in patients with HFrEF, though there's a lot of small studies showing hypothetical benefit and maybe showing short-term benefit among patients with HFrEF when it comes to hemodynamics symptom benefit. However, there is a study going on called SIL-HF, S-I-L-HF, that is currently enrolling patients. Is a phase 3 multi-center trial that is being conducted, I believe, within the United States and enrolling patients. So hopefully in the next few years we'll have more data coming out on that side as well for patients with HFrEF using the PDE5 pathway. In previous episodes, we've talked about the DAPA heart failure trial, which used dapagliflozin in patients with heart failure and reduced ejection fraction, irrespective of the presence of diabetes, and showed pretty significant benefit when it came to cardiovascular death or heart failure hospitalization. I was recently, just last week, approved by the FDA for use in patients with HFrEF, irrespective of the presence of diabetes. Just to put it into context, DAPA heart failure studied a fairly high-risk group of patients. But if you look at the mortality in DAPA heart failure at 1.5 years, it was 11.6% in the treatment arm and roughly 13.9% in the control arm. So you can imagine that the Victoria group studied a much higher risk population, studied a very sick subset of HFrEF patients. The next study I want to briefly talk about is Caravaggio. Caravaggio is looked at Apixaban for the treatment of venous thromboembolism associated with cancer. There's more data coming up on safety and efficacy of using DOACs or direct-acting oral anticoagulants among patients with DVTs and PEs with underlying cancer. As we know, warfarin is really not a favorable drug in this population. We have been using low molecular weight heparin such as enoxaparin or dalteparin in these patients, typically for venous thromboembolism. Prior to this study came out, we had some good data for use of oral edoxaban, which is the Hokusai VTE study, and Rivaroxaban, the treatment of venous thromboembolism in patients with cancer. However, the benefit of these oral agents was limited by the increased risk of bleeding. So this study was a non-inferiority study. It was an industry-funded trial. It was funded by Bristol Myers Squibb Pfizer Alliance, and it was a multinational randomized investigator-initiated open-label non-inferiority trial with blinded central outcome adjudication. They randomly assigned consecutive patients with cancer who had symptomatic or incidental acute proximal DVT or pulmonary embolism to receive either oral Apixaban. They used 10 milligrams twice a day for 7 days, followed by 5 milligrams twice daily, or subcutaneous dalteparin, which is a low molecular weight heparin, in the control arm. The treatments were administered for 6 months, and the primary outcome was objectively confirmed recurrent venous thromboembolism during the trial period. Principal safety outcome, of course, was major bleeding. And they found that recurrent venous thromboembolism occurred in 5.6% of patients in the Eliquis arm or the Apixaban group, compared to
7.9% in the delta parent group. This p-value was less than 0.001 for non-inferiority. Major bleeding occurred in 3.8% in the Apixaban group and 4.0% in the delta parent group. So they concluded that oral Apixaban was really non-inferior to subcutaneous delta parent for treatment of cancer-associated venous thromboembolism without an increased risk of major bleeding. I think this study continues to bring a lot of evidence forth for using these factor Xa inhibitors among patients with cancer-associated DVTs and PEs. When you break down the study population as to look at who was studied, the mean age in the study was 67.2%. Half of the patients were male. Their mean weight was around 75 kilograms. Really a small fraction of the patients had significant CKD, with only 9 to 10% of the patients having a GFR less than or equal to 50. You can say the breakdown for DVT and PE was fairly even with 50-50. 97% of the patients did have active cancer, and 2/3 of the patients had recurrent locally advanced or metastatic cancer, with most patients either being on treatment at enrollment for cancer or having been treated for cancer within the previous 6 months. Now, the safety outcome, as I said, was major bleeding, which was similar in the two groups. When it came to non-major bleeding, the episodes were slightly higher in the Apixaban group, but this difference was not statistically significant. I think having safety data for a drug like Eliquis or Apixaban is helpful for using DOACs in this population, because as you can imagine, we know that there is more data showing safety of using these drugs among patients with more advanced renal disease, which may happen among patients with cancer as they develop either kidney dysfunction, acute or chronic kidney dysfunction. At the same time, this group of patients was not specifically studied in this randomized control trial. The next study I want to talk about is using Rivaroxaban in peripheral arterial disease after revascularization, the Voyager PAD study. It was funded by Bayer and Janssen Pharmaceuticals. If you remember, the Compas Trial, which was published in the last couple of years, really brought forth the use of low-dose Rivaroxaban, and the subgroup of peripheral arterial disease was the one that did see some benefit from using this. So this is a randomized control trial looking at that specific group of patients. And here's what they found. So who was studied? It was patients with PAD who had undergone lower extremity revascularization that was either randomized to receiving 2.5 milligrams twice a day of Rivaroxaban plus aspirin, or placebo plus aspirin. The primary efficacy outcome was a composite outcome of acute limb ischemia, major amputation for vascular causes, myocardial infarction, ischemic stroke, death from cardiovascular causes. Principal safety, of course, was major bleeding, defined according to the TIMI classification, and major bleeding as defined by the ISTH was a secondary safety outcome. Total of 6,500 patients roughly underwent randomization. 3,286 in the Rivaroxaban arm, 3,278 patients in the placebo group. The primary efficacy outcome occurred in 508 patients in the Rivaroxaban group and 584 in the placebo group, which is basically 17.3% versus 19.9% at 3 years. Hazard ratio 0.85, p-value 0.009. TIMI major bleeding occurred in 2.6% of the Rivaroxaban group and 1.8% of the placebo group. Hazard ratio 1.43, p-value not statistically significant but barely missing significance at 0.07. The secondary outcome, which was another different classification of bleeding, the ISTH major bleeding, however, was more common, with 5.9% in the Rivaroxaban group versus 4% in the placebo group. Hazard ratio 1.42, p-value of 0.007. So the authors concluded that in patients with peripheral arterial disease who had undergone lower extremity revascularization, using low-dose Rivaroxaban of 2.5 milligrams twice daily plus aspirin was associated with a significantly lower incidence of the composite outcome of acute limb ischemia, major amputation for vascular causes, MI, ischemic stroke or death from cardiovascular causes compared to just aspirin alone. While the TIMI major bleeding was no different between the two arms, there seemed to be a signal that bleeding was slightly higher in the Rivaroxaban arm compared to using placebo with aspirin in both groups. So if you look at who was studied in this specific Voyager PAD study, the median age of the patients was 67 years. Again, 3/4 of the patients were male, 80% were Caucasian. Study was, again, across multiple continents, including South America, Asia Pacific, Europe, and North America, with a large majority of the patients coming from Eastern and Western Europe. The median ABI in these patients was 0.56 at baseline. Roughly 6% of the patients had previous amputations, 95% had some history of claudication, 30% had a history of critical limb ischemia, and 36% had roughly some previous peripheral revascularization. So these were patients with pretty significant peripheral arterial disease. The other thing you want to look at is what other medications these patients were on, at least at baseline before the study. And statins were present in 80% of the patients, ACE inhibitors in roughly 60-65% of the patients. Aspirin at randomization was present in 99% of the patients, and Plavix in 50% of the patients. So like I said, over 3 years, the absolute difference in the primary efficacy endpoint was 15.5% versus 17.8%. That's an absolute difference of 2.3% over 3 years. So that's close to 0.8% a year. That's 125 number needed to treat per year. And the majority of the benefit comes from acute limb ischemia, because that difference was an absolute difference of 2.2% between the two groups. The rest of the endpoints, including major amputation for vascular causes, MI, stroke, and death, really were fairly similar in both groups. So again, all the benefit for Rivaroxaban came from a reduction in acute limb ischemia. As far as I know, this specific dose of 2.5 milligrams twice a day is still not available for use within the United States. Now, you could argue that actually, currently, practice guidelines recommend using aspirin or Plavix monotherapy for patients with symptomatic peripheral arterial disease. However, there are certain groups of patients that do receive dual antiplatelet therapy with aspirin and a P2Y12 inhibitor or Vorapaxar in certain cases. So the control group was a single antiplatelet agent. It was not a dual antiplatelet agent. And maybe that may have been a better true control, but at the same time, practice is fairly variable when it comes to treatment of PAD. And the authors commented in their discussion that our results extend and complement the observation in the cardiovascular outcomes for people using anticoagulation strategies, which is the Compas Trial, which showed reductions in ischemic risk, including the risk of limb outcomes, such as acute limb ischemia in a broad group of patients with chronic PAD enriched for polyvascular disease. Together, these trials show the efficacy for Rivaroxaban at a dose of 2.5 milligrams twice daily added to aspirin in peripheral arterial disease from its initiation after the lower extremity intervention and continuing through long-term prevention. I do believe after looking at this study that once this dose does become available, I can see more PAD patients getting intervention, ending up on this cocktail of Rivaroxaban and aspirin. Of course, we had more DOAC trials. By the way, all these trials were published in the New England Journal of Medicine. We had the Rivaroxaban or enoxaparin in non-major orthopedic surgery, the Pronamos study. This study was funded by the Central Hospital University of St. Etienne at Bayer. I'll keep it short. I mean, this was a study that randomized 3,600 patients, roughly 1,800 to receive Rivaroxaban, close to 1,800 to receive enoxaparin. These were adult patients who underwent lower limb non-major orthopedic surgery and were considered to be at risk for venous thromboembolism on the basis of the investigator's judgment to receive either of these two drugs. The primary efficacy outcome was major venous thromboembolism, a composite of symptomatic distal or proximal DVT, pulmonary embolism, or venous thromboembolism related death during the treatment period, or asymptomatic proximal DVT at the end of treatment. Test for superiority was planned if Rivaroxaban proved to be non-inferior to enoxaparin. Pre-specified safety outcomes included major bleeding, which was fatal, critical, or clinically overt bleeding, or bleeding at the surgical site leading to intervention, and non-major clinically relevant bleeding. Just so you know, the rates of venous thromboembolism were very low in the trial. 0.2% of the patients receiving Rivaroxaban actually had a major venous thromboembolic event. That's only 4 of 1661 patients that we had the data for in the end, compared to 18 of 1,640 patients, amounting to 1.1% in the enoxaparin group. Risk ratio with multiple imputation, because they had to impute values for missing data, was 0.25, p-value less than 0.001 for non-inferiority, and because they met non-inferiority when they did their superiority analysis, the p-value was still significant at 0.01, stating that Rivaroxaban was superior to enoxaparin in preventing major venous thromboembolic events. The incidence of bleeding did not differ between the two groups, really being 1.1% and 1.0% in the two groups. The authors concluded that Rivaroxaban was more effective than enoxaparin in the prevention of venous thromboembolic events during a period of immobilization after non-major orthopedic surgery of the lower limbs. Looking at who was studied in this trial, the median age was 41 years, with 2/3 of the patients being male. These were mostly what looks like young, healthy males, because their median hemoglobin was 14.6, median creatinine was 0.87. More than 84%, close to 84% of the patients had a creatinine clearance of 90 ml per minute or more. Rate of diabetes in this whole population was as low as 4.4%. Close to 3% had coronary artery disease. 1% had a history of venous thromboembolism before. Roughly 1 to 2% of the patients were on aspirin at baseline. And most of these patients, the intended treatment duration when the study started was going to be less than 2 months. So the authors concluded that in this trial of pharmacologic thromboprophylaxis after non-major orthopedic surgery, treatment with Rivaroxaban, an orally active direct inhibitor of factor Xa, was associated with a 75% lower risk of major venous thromboembolism through the end of treatment than enoxaparin. The use of Rivaroxaban was not associated with a higher incidence of major bleeding or other bleeding events. They do concede that there's really no consensus when it comes to guidelines. When you look at American guidelines, they are actually relatively more conservative and do not necessarily recommend thromboprophylaxis for all patients compared to the European guidelines, which do recommend some kind of prophylaxis, especially using low molecular weight heparin during the period of immobilization. But one of the big limitations of the study was premature discontinuation of enrollment, resulting in a smaller than planned sample size, limiting the precision of the efficacy estimation. And as we know, a lot of the times when studies are stopped early, you may overestimate the benefit of the study drug. All in all, I think the event rates were pretty low using Rivaroxaban when it comes to venous thromboembolism, and bleeding rates are also pretty low. So it seems fairly safe to use in this population. One of the studies I was really looking forward to was the Tailor Pci study. Now that study has not been published, so I can't really give you a lot of details on the specifics, and we can go over the overall results. But the reason it was so important, so interesting, was because it was a follow-up to the popular genetic studies, which you may have heard on one of our previous episodes. The popular genetic study was published in the New England Journal last year. And just to briefly go over what that study did was it had roughly 2,500 patients. It randomized patients undergoing PCI to genotype-guided selection of oral P2Y12 inhibitor. So patients were randomized in that study in a 1-to-1 fashion to receive either a P2Y12 inhibitor on the basis of early CYP2C19 genetic testing, which is the genotype-guided group, or standard treatment with either ticagrelor or prasugrel, which was sort of a standard treatment group for 12 months. And then in the genotype-guided group, carriers of CYP2C19-2 or CYP2C19-3 loss of function allele received ticagrelor or prasugrel, and the non-carriers received clopidogrel because the former group was maybe more resistant to clopidogrel and more likely to have events. So they chose a more genotype-guided approach. When they looked at the primary efficacy endpoint and they looked at the rate of death from any cause, MI, definite stent thrombosis, stroke, or major bleeding, and they found that using this genotype-guided strategy, in which patients without a CYP2C19 loss of function allele received clopidogrel, there was really no difference in the rate of combined death from any cause, MI, definite stent thrombosis, stroke, or major bleeding 12 months after PCI, compared to standard treatment with the more potent P2Y12 inhibitors, ticagrelor and prasugrel. Secondly, the use of clopidogrel in the genotype-guided group resulted in a lower risk of mostly minor bleeding. So maybe some benefit when it comes to minor bleeding. Tailor Pci was a much larger study. It was NHLBI funded, an international trial that enrolled 5,300 patients who had PCI with at least one stent for acute coronary syndrome or stable coronary artery disease
for at least 12 months. 5,302 patients were randomly assigned either to the conventional arm therapy, which received clopidogrel 75 milligrams daily, or the prospective genotyping arm, where the presence of CYP2C19-2 or 3 mutation carriers received ticagrelor 90 milligrams BID. Patients that did not have this specific mutation or were non-carriers received clopidogrel 75 milligrams daily. Median age of the trial participants was 63 years, 3/4 of them being male. If you look at the genotype breakdown, 1/3 of all patients were carriers of this CYP2C19 2 and 3 mutation, which makes them more likely to be resistant to clopidogrel as they aren't able to metabolize clopidogrel well and were given ticagrelor. In the study, they used the Spartan RX technology, which is a rapid genotyping platform able to determine CYP2C19 allele status within 1 hour. The comparison for the primary endpoint was performed only among patients who were mutation positive, which comes to roughly 900 patients in each arm. At the outset, the expectation was using a genotype-guided strategy would result in a 50% reduction in the primary endpoint. However, the study did not meet its primary endpoint and resulted in a 34% relative reduction, 1.8% absolute reduction in the primary endpoint within the genotype-guided therapy with a p-value of 0.056, barely missing significance. In the secondary outcomes, there was no difference in the terms of TIMI minor or major bleeding at 12 months. A pre-specified multiple recurrent events analysis showed that for the genotype-guided strategy, there was actually a significant reduction in adverse events when compared with standard care strategy. Hazard ratio 0.60, p-value 0.01. A post-hoc analysis of the primary endpoint of the first 3 months after randomization showed a significant reduction of adverse events in the genotype-guided strategy. Again, hazard ratio 0.21, p-value of 0.001, really indicating that the benefit of using this genotype-guided strategy came early, especially within the first 3 months. The conclusion of the study was that a genotype-guided oral P2Y12 inhibitor strategy compared with the conventional clopidogrel therapy with point-of-care genotyping in CYP2C19 loss of function patients with acute coronary syndrome and stable coronary disease undergoing PCI did not result in a significant reduction in ischemic event at 12 months.
However, it got really close. Also, these results are in line with the pre-existing evidence of the popular genetics trial. While the trial is not yet published, the results of the Tailor Pci trial are compelling and may provide an impulse for the implementation of more precision medicine in the form of genotype-guided therapy for dual antiplatelet therapy in clinical practice. Also, looking back at previous trials looking at different antiplatelets, we've seen several studies that have shown contrasting results or contradictory results. So maybe this genotyping platform, which is quick, hopefully easily available, can be used in practice more often. It may even save costs at the end of the day because you end up using clopidogrel or Plavix, which we know is cheaper, in at least 2/3 of the patients. Finally, let's not forget the high prevalence of this loss of function mutation among the general population. Up to 1/3 of the population within the United States has this mutation. That increases to up to 50% among Americans of Asian heritage. Moving along, the ischemia studies have finally been published in the New England Journal of Medicine. In our previous episode, we've already discussed the ischemia study at length when they were presented at the meeting, at the AHA meeting, I believe. And looking at the paper, of course, it gives you greater insight into some of the more specific details, but the highlights and the conclusions remain the same. You know, when you look at the ischemia CKD study with roughly 777 patients, they concluded that among patients with stable coronary disease, advanced chronic kidney disease, and moderate or severe ischemia, there was really no difference in using an initial invasive strategy as compared to an initial conservative strategy. Also, remember that the invasive strategy in this subgroup was associated with a high incidence of stroke, hazard ratio of 3.76, p-value of 0.004, and a higher incidence of death or initiation of dialysis, hazard ratio 1.48, p-value 0.03. Studies from the original ischemia trial, which had 5,179 patients with moderate or severe ischemia. These results were also published. And just to summarize the results from the ischemia trial, as you all know, over a median of 3.2 years, among patients with stable coronary disease and moderate to severe ischemia, there was really no difference in using an initial invasive strategy compared to an initial conservative strategy when it came to reducing the risk of ischemic cardiovascular events or death from any cause. I want to spend a few minutes talking about who was studied because there's been a lot of controversy, a lot of arguments. So it's important to know who was studied in this population for you to be able to use these results in your practice. Median age in this study was 64 years, interquartile range of 58 to 70 years. Again, 3/4 of the patients were male, 2/3 of the patients were Caucasian. Only 4% in the whole study were African American. When you look at the patients who had previous MI, you can see 1 out of 5 patients had a previous myocardial infarction. Again, 21% of the patients had a previous PCI, 4% of the patients had a previous bypass. Median ejection fraction in the study was 60%. Very small proportion of the patients had heart failure. Single digits when it came to prior cerebrovascular disease or peripheral arterial disease. When it comes to angina, really 90% of the patients did have a history of some kind of angina. 20% of the patients having daily or weekly angina, 44% of the patients having angina several times per month, and 1/3 of the patients having no angina in the previous 4 weeks. Do not forget that you had to rule out left main disease before you could actually go ahead and randomize patients in this study, and close to 3/4 of the patients, they used CT instead of angiography in the cath lab to rule out left main disease. There is another misconception for some reason that patients with severe ischemia were not included in the study. That is not true. If you look at the number of patients who had severe ischemia, over half the patients in the study had actual severe ischemia. Really 54.8% of all patients having severe, 33.3% having moderate ischemia, and then 11.9% having none or mild. This is data from the core laboratory. 1 out of 10 patients did have really mild ischemia in this study, even though it was always designed to study moderate to severe ischemia. In a forest plot that they tried to analyze the heterogeneity in treatment effect when it came to primary outcome, all lines seemed to cross the midline, and there was really no clear benefit for invasive strategy over the conservative strategy in any specific population. Maybe there was a trend among patients who had more severe ischemia and more severe coronary artery disease. I'll end it with the last mention on what really medical therapy meant in ischemia. I think you hear conservative strategy or medical therapy. What does that really mean? So what medications were they really talking about? I'll go over the use of specific medications within this trial, and it was fairly similar when you look at the invasive and conservative arm. So antiplatelets or anticoagulants were used in almost 100% of the patients in this study. Statins, there was a high statin use with 95% of the patients being on a statin, 40% of these being on a high intensity statin. 4% of the patients had additional use of ezetimibe. 2/3 of the patients were either on an ACE inhibitor or an ARB. And adherence to these medications was close to 74% at baseline, and if anything actually improved over the course of the trial to being 81, 82%. So relatively high adherence to these medications. For angina relief, of course, there was a high use of beta blockers in this study. If you look at the course of the study, roughly 80% of the patients were on a beta blocker throughout the study. 1/3 of the patients were on some calcium channel blocker in both study groups. Slightly higher use in the conservative arm. Other anti-anginal medications, actually commonly using long-acting nitrates. Roughly 40% of the patients were on a long-acting nitrate, roughly 1 to 3 months after study initiation, compared to 20-25% in the invasive arm. And the use of long-acting nitrates seemed to be higher over the entire study duration. By the end of the study, 1/3 of the patients were on a long-acting nitrate in the conservative arm, compared to maybe 1 out of 5 patients in the invasive arm. Dual antiplatelet use, as you can imagine, was of course high within the invasive strategy arm, especially for the first 12 months. Roughly, the peak was around 60% of the patients in the invasive arm received some kind of DAP therapy. Interestingly, within the conservative arm as well, but if you look at the 3-month mark, roughly 20% of the patients were on DAP therapy. And if you look at the end of the study at 60 months, 15 to 20% of the patients in both arms were on dual antiplatelet therapy. Not all patients within the invasive arm received revascularization. On the other hand, there was definitely crossover with patients in the conservative arm crossing over to receive some kind of revascularization. This is expected, as we know from Courage and Barry 2D previously, where there was always crossover within the medical therapy arm over time, with patients getting some kind of revascularization strategy, commonly for symptoms, over the course of the study. In the invasive strategy arm, revascularization was performed in close to 75 to 80% of the patients by the end of 1 year. So not all patients who were in the invasive arm received some revascularization. And the reason for that is I think 1/3 of them had no disease, despite having a positive stress test, and a significant proportion had very severe disease that was not easily revascularizable. So if you look at the end of the study, around 5 years, close to 80% of the patients in the invasive arm had some revascularization performed, 25% of this being bypass surgery, 75% getting some kind of stenting procedure. In the conservative arm, on the other hand, the rate of revascularization slowly increasing, but the highest rate of rise being in the first year, where close to 10% had received some kind of revascularization. By the end of 5 years, that number being close to 20%. My take from this study is that you can safely start medications among patients with moderate to severe ischemia as long as you rule out left main disease, and you can use either a CTA or a CAT to rule out left main disease. You put them on the medications that we just spoke about. If they have refractory breakthrough angina, then I think you may want to move to a revascularization strategy. Or if they have adverse events to the medications or patient choice, maybe to go for a revascularization strategy early, both being reasonable as long as they understand the risk-benefit pros and cons of either strategy. It would be very helpful to have longer-term data, as we know that the curves were crossing each other and possibly favoring PCI when it comes to the rate of spontaneous MI. There's going to be definitely interest in obtaining some long-term data within this group of patients. At the end of the day, when it comes to a hard outcome such as mortality, there's really no difference in using invasive strategy. We will end this episode with information on 2 non-randomized control studies. They do enhance our knowledge in the field of structural heart disease. The first one being Evolute Low Risk Bicuspid Study, which was presented again at ACC 2020. As we've discussed in the early part of this episode, bicuspid valve disease constitutes a significant proportion of patients with aortic stenosis, and these patients are commonly younger than those with degenerative tricuspid aortic stenosis, hence at a lower risk for SAVR. Randomized control trials have excluded patients with bicuspid valve disease, so it's really unclear, even though there is some retrospective analyses that have been done and shown safety of using TAVR in this population. It has not been studied very well in a prospective, systematic manner, as was done in this study. They used a core valve, which is the Medtronic valve in this study, because the investigators believed that its design permitted the use of its ovoid profile at the annular level. The maybe better to use in somebody with a bicuspid valve annulus, because it maintains the circular profile of the supraannular valve prosthesis. Patients enrolled in the Evolute Low Risk Bicuspid Study were older than 60 years, had symptomatic severe aortic stenosis with CT-confirmed bicuspid morphology, and the absence of aortopathy, which is an ascending aorta of more than 4.5 centimeters. The STS predicted risk of mortality, or the PROM score, was less than 3%, so relatively low-risk group. Only one of the screened patients was excluded on the basis of excessive LVOT calcification. The remaining 150 patients underwent TAVR, and it was successful in 149 patients. 90% of the patients had at least a single RAFI on their bicuspid valve, and the valve views were Evolute R in 43% and Evolute Pro in 57% of the patients. Valve sizing was based on CT measurements of the aortic valve annulus, and pre-dilation was recommended. One patient underwent conversion to SAVR. They had 30-day follow-up. Again, mean age was 71 years, 52% of the patients being men, mean body surface area 1.9 square meters. Mean STS PROM score actually was only 1.4%, so relatively, again, low-risk population than those previously reported in the pivotal TAVR trials. Iliofemoral access was in 98.7% of the patients, general anesthesia used in 63.3% of the patients. Primary endpoint of death or disabling stroke occurred in 1.3% of the patients at 30 days, and non-disabling stroke occurred in 3.3%. There were no annular ruptures. Permanent pacemakers were placed in 15.1% of the patients without pre-existing pacemakers. At 30 days, there was significant improvement in the NYHA class. Again, 75% were in NYHA class 1 by the end of 30 days, 22% in NYHA class 2. Patient prosthesis mismatch was absent in 87% of the patients, moderate in 7.6%, but severe in 5% of the patients. Mean gradient across the valve was 7.6 millimeters of mercury, and a mean effective regurgitant orifice area of 2.3 centimeters square. No patients had moderate or severe AI, but mild AI was present in close to 60% of the patients. As we know, the self-expanding valves are hemodynamically quite favorable, with
lesser patient prosthesis mismatch, and really lower mean gradients compared to the balloon expandable valves. And this study highlights the need for much longer-term follow-up of at least 10 years when we're evaluating low surgical risk patients for TAVR.
The other study I wanted to mention briefly was the Global EXPAND study. This study was contemporary outcomes with using the MitraClip NTR or XTR system in primary mitral regurgitation. The MitraClip EXPAND study was a large, prospective, single-arm observational study of over 1,000 patients undergoing transcatheter mitral valve replacement with the MitraClip system, which is owned by Abbott across the United States, Europe, and the Middle East. What is interesting about these NTR and XTR clips, which were introduced only in 2018, was that they have offered design improvements over their predecessors with respect to catheter delivery system and clip arm lengths, the lengths being longer, which means you could actually increase the potential number of patients who could benefit from this therapy, and you could use these clips across larger degrees of valvular dysfunction when it comes to primary mitral regurgitation. In this study, they actually just gave information on 422 patients with primary or mixed mitral valve pathology and really focused on 30-day outcomes. This patient population was pretty old, the mean age being close to 80 years. It was a medically complex group with cardiac arrhythmia in 60% of the patients, prior heart failure hospitalization in the previous year, and 43% of the patients, renal failure in 28%, 52% of the patients being male, 48% being female. Implantation rate was 99.5%, so very high procedural success rate. And acute procedural success being defined as a residual mitral regurgitation of 2+ or lower at discharge and no requirement for mitral valve surgery was achieved in 94.5% of the patients. Among these two clips, they noted that in patients with more complex mitral valve anatomies, that is wider flail gaps, more calcified landing zones, greater MR reduction was observed with the use of the XTR device compared to the NTR clip, p-value of 0.03. Again, overall, the 30-day major adverse event rate was fairly reassuring. All-cause death 2.4%, stroke 1.2%, 0% MI rate, and then cardiovascular surgery for device-related complications being 0.9%. Single leaflet device attachment or leaflet perforation occurred in 1.9% and 0.2% of all cases, respectively. At 30 days, residual mitral regurgitation of 2+ or less was achieved in 97.3% of all patients. So this was a fairly good study showing that these newer generation of MitraClip NTR XTR devices are both safe and efficacious for treatment of symptomatic primary mitral regurgitation in a contemporary real-world population, and possibly offer the ability to expand its use among
patients with more severe prolapse, larger flail gaps, more complex anatomical disease.
Of course, we have to look forward to getting data out to 1 year. So that brings us to the end of this episode. We hope you enjoyed this episode. We covered a wide range of clinical studies being presented at the American College of Cardiology 2020 meeting.
If you enjoyed our episode, don't forget to like, subscribe, and give us a high rating, as it helps other listeners find us. You can leave your suggestion for topics, critiques, things you think we can do better. You can email us at heartsuccessteam@gmail.com. You can actually find us on our website at www.heartsuccess.info. Our website now also provides links to all the podcast providers where you can listen to this episode. You can find us on our Facebook page at Heart Success Team, or you can always reach me on Twitter at CardioBro.